Good morning. It's great pleasure to introduce Dr. Abazovic, Vice President of SEBRA, expert in the field of regenerative medicine. This meeting, Dileme and Kontroverze, is now, we can say, traditional with intention to make bridges between different fields. Today, we start with regenerative medicine. Thank you, Jihan, about that. Thank you for organization this event. And I will say to you that you can start with your session. Thank you.
Thank you very much. I want to thank organizer for giving us the opportunity to maybe put a little bit closer some very new therapies. I mean, maybe they are not very new now, but using of stem cells and regenerative medicine in our everyday practice. So for this purpose, since that this is, let's say, my field of expertise, but as we can know, nothing is possible to do it by yourself. I really want to thank Dr. Milutin Bulajic, who arrived from Italy even in this difficult times for traveling, and Dr. Lenart, who also arrived from Slovenia, and they will share our experience in the using of the newest technologically most advanced therapies in everyday practice. Of course, according to the situation, and since that all the regenerative medicine it's mostly based on the immunology, we also invite our distinguished professor from military hospital in Belgrade, and unfortunately, because again of this COVID situation, they were not able to come, but they will join us through the Zoom. Dr. Lenart is microbiologist, and his PhD is about the stem cells differentiation, and he is working for the company which is based in Slovenia, and which, believe me or not, works 25 years in field of producing of cell therapy. So I will invite him as a first speaker to told us about specific product which they named ImmunoArt, and show us the possibilities for using of this kind of treatment in the bowel disease. Thank you.
Thank you very much to organizers for the invitation and the possibility to present the work we've been doing all these years. So yeah, and especially the organizing committee for this session, which is really what we believe in. So today I would like to talk about how can cell therapies benefit patients with some of the gastrointestinal diseases, at least the ones we've been dealing with. So, like Jihan said, we've been established in 1997 for developing cell therapies which could benefit patients. So we've been doing this mission for quite a while now. In 2008, we were also the first cell and tissue establishment in Slovenia, authorized by our agency, and we're well connected with all stakeholders in the field. So our first products were actually the cultivation of chondrocytes. This is not really gastrointestinal problem, it's orthopedic, and later on it was also one, it solved one urological problem, but we've been doing almost 20 years, we've been producing this treatment, so we learned quite a lot during that time. Nowadays, I'm quite proud to say that also partly because of us, but of course because of the clinicians we're working with, Slovenia is in the top portion of countries which with regards to how many cell therapies patients get per capita. This is in the latest report by Ivan Martin. So how did we get into gastrointestinal field? It was actually through hematologists, pediatrical oncologists. So we got a call by them regarding 17-year-old patient with acute graft versus host disease, which is a life-threatening complication of bone marrow transplantation, or specifically of hematopoietic stem cell transplantation. The disease was refractory to corticosteroids and biological drugs, so complex and really life-threatening disease. And he had more than 15 liters of diarrhea per day, which meant that it was a severe gastrointestinal problem, which hematologists were dealing with due to the nature of the disease. So actually MSCs were the only solution for the patient then. So in August 2014 they called, can you do something? In 2 months we were able to prepare, due to our expertise on how to produce safe and effective cell treatment and our knowledge about MSCs, we were able to produce first systemic application of MSCs, which went nice, and actually the result was really astonishing. It was the reduction of diarrhea from 15 liters to 1 liter a day, which is then bearable, which was bearable by the patient. So then during my PhD, I was convinced that mesenchymal stem cells are only good for their differentiation capacity, so because they're able to differentiate into different tissues, but later on it actually turned out that possibility to be more or less in the second part, but the first part is actually their intrinsic their possibility to act as a trophical agent, and of course their anti-inflammatory or immunomodulatory effects are really starting to be appreciated lately. So in gastroenterology, when we started talking with our clinicians, we found that these inflammatory or immune-driven GI diseases were the target to go for, or liver diseases. We were thinking about 2 types of stem cells, so hematopoietic stem cells, which of course have the problem with life-threatening adverse events, and MSCs, which we knew were at that time, we knew that they were safe to apply. So we chose mesenchymal stem cells out of sources which we could use. At that time we went for bone marrow. We could as well go for adipose tissue or cord tissue, and the mechanism of action we knew was to reduce inflammation in the first place, then due to that also reduce fibrosis and augment regeneration of the tissue. At that time we didn't have a lot of data about allogeneic transplantation of MSCs. Nowadays we're really sure when we say that this application is safe and it's tolerable by patient, and that it doesn't act with any adverse events or anything like that. Actually we're sure now, also due to our experience and also due to actually some meta-analysis, there is really a lot about, so I think this is really an issue which we can now close, that MSCs are safe, and we go forward if they are also effective. So at that time when we were starting the project with our gastroenterologists in Ljubljana, we knew we had some data about the disease and about MSCs in this disease, but not a lot. So we knew that there's with majority of Crohn's disease patients there's no problem. So we will be dealing with refractory patients to corticosteroids and biological drugs, so tough patients. Then in literature there were two articles about the administration of allogeneic cells and one about autologous cells. So the autologous part was really not as good as allogeneic. So we proposed to go with allogeneic cells. However, we didn't have that thorough knowledge as we have now about the safety of allogeneic. So we actually were then we agreed at the end with clinicians that it's safer to go with autologous. So please bear this in mind when I will go forward. So actually we went for for autologous, even though the results we knew were a bit worse. So we included at that time 4 patients. The bone marrow from those patients was aspirated. We prepared 2 doses of cells, and inclusion criteria, as I explained earlier, was Crohn's disease, where corticosteroids and at least 3 biological drugs cannot do anything. So then we started cultivating those cells and started also seeing what diseased cells actually also look like. So at first glance the cells were not looking really good. They didn't look bad, but it really seems at first glance that the cells are not as they should be. And we got some complaints in R&D. We got some complaints from production facility that this is not as we thought it would be. Okay. Then the people in the lab start complaining that actually the cells do not grow as good. So here we see a brief presentation of how cells grew through passages at the bottom. So really 2 Crohn's disease patients out of 4 grew suboptimal, while the other 2 was really they were really not growing well. Then we also performed immunomodulation of properties of these cells. So MSCs don't have the possibility to act immunomodulatory on their own. So they need to feel the environment, they need to feel the inflammation, and with results to that they become active, and they start expressing immunomodulatory properties. So therefore, if there is no activation of the cells by inflammatory environment, then there is no immunomodulatory effect. So here we can see first 3 are actually normal healthy donors, and the other 4 which have Crohn written, then they're Crohn's disease patients. And we can clearly see there are some inflammatory cytokines, not genes activated, which we were checking at the time. The most important there are IDO and TCG6. And we clearly saw, please mind that this is logarithmic scale, that actually the changes or the differences were quite significant with regards to immunomodulatory properties. So we managed to prepare the cells. We transplanted all 8 doses without any adverse event. But the results were as we already knew that they would be due to the fact that the cells were suboptimal. So patients reported improvement, but clinical improvement actually done with colonoscopy was not significant. So we actually disagree with the first study which got us into autologous field. They claim that actually autologous cells of Crohn's disease patients are fine. They're as they should be. We disagree, but this is science, of course. So yeah, from that point on, we actually want to go for allogeneic transplantation wherever possible, with systemic immune diseases. One part which is which came out later on was we could as well use umbilical cord mesenchymal stem cells, so stem cells from umbilical cord, allogeneic obviously, and they got quite nice results. The second part which I would like to talk about is what's going on with treating refractory fistulae in gastroenterology. So there's quite a lot of things going on here, quite a lot of clinical trials, and they actually all of those clinical trials, they only recruit patients which are again with complex fistulae which cannot be treated with any other method or any other drug. So even though those patients are really tough, the success rate is actually quite empowering and promising. What are the possible mechanisms of MSCs in fistulae? So they reduce inflammation when they're applied. They're usually applied locally. They reduce inflammation, and due to the reduction of inflammation, the regenerative properties or regeneration can actually take place, because until there is inflammation, there cannot be regeneration. And also the cells, they can switch, they signal, they talk to environment all the time. So actually if the cells sense that the inflammation is not there anymore, they can actually fire the regenerative things. So how we actually also what are our experience? We didn't do any complex fistulae, mainly due to the fact that our surgeons are not really sure how they would surgically go forward with this, and hopefully in the next session, in the next talk, we'll hear about something about this as well from Italy. But we know something from this first patient to come back with GVHD. Sorry about that, but this gastrointestinal form of GVHD. So this first patient was transplanted by cells from his father. So his father donated bone marrow for his son, and his son got transplanted, got those cells transplanted, and after that, also on colonoscopy, there was clear sign of improvement of gastrointestinal lesions. So this was really surprising for us at that time, because we didn't have any real experience on this field. And then we started thinking, okay, how is this? Are those cells from his father and from the son? And we were actually convinced that the cells will be from his father. So the mode of action would be cells come into a patient, Then they graft to the sides. That's what we all believed in. And differentiate it into gastrointestinal cells or whatever, and form the tissue. But when the chimerism was done by a piece of biopsy taken from the point of lesion, or I think it was few lesions, we could not detect one single cell or any polymorphism by cells from his father. So actually, this patient regenerated the gastrointestinal tract by on his own, due to the fact that his father's cells actually lowered the inflammation and enabled cells to really do what they're there for, which was really an astonishing find for us. Just to briefly tell you about the engraftment, in systemic application, it's usually 0.1% to 2.7% of cells are actually being engrafted, and the rest just get lost in the way. For this treatment, there is one registered cell drug, this advanced therapy medicinal product in EU. I don't know if it's available in Serbia or Montenegro. In Slovenia, the drug is available. However, I think it works really nice, but it seems to be prohibitively expensive. And what we get from the field, from the market, from the patient, that not a lot of patients get this, even though they would be here actually they would be fine for this application. And the last part, which could be interesting for gastroenterologists here, is liver. So there are quite a lot of clinical trials going on of how MSCs can be used, so mesenchymal stem cells can be used for the treatment of liver diseases, mainly cirrhosis and some other things. The majority uses bone marrow, mesenchymal stem cells. Some use umbilical cord, and few use adipose-derived stem cells. The majority, obviously, of the clinical trials goes on with regards to allogeneic cells, which we would go for as well. Intravenous seems to be the main route of administration. So these are only a few of the clinical trials. It's really a lot going on, but the majority of studies are still ongoing. So there's not a lot of really good and thorough clinical phase 3 clinical trial results. What is known is that the application of MSCs is safe, which hopefully I managed to persuade you throughout my presentation. There is actually in some of them, or in the majority of them, there is high percentage of patients with improved liver function, and even the reduction of fibrosis in some cases, which is interesting. But some studies, of course, show no statistical significance. So what we see for the future is that NASH, so non-alcoholic steatohepatitis, seems to be the next big thing due to the pandemic of obesity and stuff like that. So hopefully we'll hear this also in the next presentation. But due to the fact that it's a complex disease, we didn't really go into it. And in Slovenia, there is still quite some cases of alcoholic cirrhosis. I don't know about here. The problem is with this is that actually our doctors are not really fond of those patients. Those kind of treatments where it's a lot of fuss, a lot of different stakeholders needs to be aligned and stuff like that. It's really hard to go forward with this. So yeah, this is pretty much what I've been had prepared. So yeah, the question is what can cells do for you?
Thank you, Leonard, very much for sharing your experience with us here. I would just like to underline a couple of things which you say, is that I see that most, not maybe most, but there are a lot of gastroenterologists in the audience. If I understand you well, you told when you discuss about Crohn's disease that the actually problem with autologous stem cells, or with the stem cells taken from the patients who suffer from Crohn's disease, you were not able to ingrow, actually, to multiply them.
Yes, we were at the end. We were able to multiply them, but they were just not acting as they should. They the growth was really impaired. We needed to recultivate them many more times than healthy patients, and it was really a pain to grow them. We succeeded due to our really long experience, but it was actually a pain. Later on, we started thinking about that most probably this is only a consequence of the disease. But then some papers also came in where it could be that also MSCs could be part of the problem of the disease, but this still needs to be thoroughly seen how this actually works. But I'm convinced that they're included in the disease either as a consequence or as part of the problem.
Thank you for clarifying this for me. Dr. Vlad, I have a question, please.
Thank you for a great lecture, really. I would ask you, I want to underline interplay between gut microbiota and this your work, which is great. And I would ask about possible joint treatment with FMT and stem cell transplantation. In relation with Crohn's disease, and also in relation with an NFLD and NASH, because it's same mechanism. It's gut-liver axis and complex interplay inside of gut, together with microbiota, receptors, hormones, all stuffs, and stem cells. Do you have some experience with together project, and do you have a plan with that? Thank you.
Yes, we've been. Thank you. It's a really good question, actually. We've been discussing this with our gastroenterologist, and we think that it would be really interesting, or it should be beneficial. Theoretically, it should be even more beneficial than it is. But the problem is then that in Slovenia we couldn't find anyone who'd actually work on the FMT. So at least to be really to have a clear knowledge about what he's doing and how he's managing it. So therefore we didn't go into, but we would gladly try that.
Okay, thank you. Just more question, because you mentioned in Crohn's disease your results. In Crohn's disease, his big problem is diversity, lower diversity of microbiota, and with stem cells you can make a higher diversity of microbiota. Also, in Crohn's disease, in relation with the FMT, is very tricky situation because FMT can't in quorum sensing in Crohn's disease, communication between bacteria in Crohn's disease is very strong, and with FMT we can't do anything for Crohn's disease. Maybe for ulcerative colitis modestly, but for Crohn's disease no. But maybe I now think about that. Maybe together with stem cells and FMT, we can broke quorum sensing of bacteria. It's very, very, very good.
I am a microbiologist by training, but my heart is not there. I'm with human cells, so we won't go into that. But I personally really believe that FMT should be investigated quite further for this. Especially these complex diseases, but combination should be, of course, good with stem cells, because stem cells, they don't really affect any of that. They just lower. There's something natural which is there, and they don't really affect. They just help.
Okay, thank you, Dr. Bezmarevic.
Okay.
Thank you very much for a great presentation. I arrived just a little bit later, but what I saw here, it was very great. We intend to name this session "New Kids on the Block," and indeed, this is the new area in medicine, new implementation of treatment strategies, not only in gastroenterology but in neurology, in a lot of medical areas, but. When you mention here Crohn's disease and complex perianal fistula, I read maybe half year ago one paper from Spanish authors. I think that was a study group for Barcelona. They have a lot of experience in this area, and I would like to ask you, I'm a surgeon, and you need to convince me why I need to use stem cells. But in that study I read before, the results were great. But there is only one thing I need to mention, that is the lack of long-term results in Crohn's disease. That is problem for surgeon also. We have recurrent fistula, perianal fistula. It's complex fistula, and supralevator fistula, with a lot of complications after the surgical procedure, increased morbidity in such patients, and you need to explain me, do we have some long-term results in terms of stem cells therapy in perianal fistula, complex fistula, and what is the cost, the benefit on such kind of treatment, because we are not in European Union. We are in Serbia and Montenegro, and we need randomized, well-designed, randomized controlled trials in unretractable perianal fistula here in patients with IBDs, Crohn's disease. So maybe we will have better results of this. But what is the long-term results, on your opinion, and what is the cost benefit of such kind of treatment?
Yeah, thank you for the question. First, let me assure you that in EU it's the same problem. There's not like that here you can't afford the cell treatments. Also in EU it's a big problem with financing of these treatments. What I am sure is that that those treatments, of course, have their price, which is not low. And therefore it will never be, cell treatments will never be meant for everybody, for all the patients which you get. So it's meant only for the patients which are really refractory, which are really complex, which do not act on any of the drugs you're using normally. Usually so far it's done on patients which surgeons don't really know what else to do. And with this in mind, actually, it's easier then to say, the long-term data, I'm not sure about that, and I don't think it's really that everybody is convinced in the field that there is long-term for sure benefit, and let's go for it like all in. And this really needs to be clarified. It needs to be studied further. But I think at the end, for these really complex people, where the burden of the system is also not only their treatment, not only when they see a surgeon, but also when they cannot work. Sometimes it's, of course, you know better than me that some patients are young. They would like to be active. They would like to be productive part of the society. And if the disease prevents them from doing this, I think the cost benefit is really there. But of course, we will not be sure until there is really thorough phase 3 clinical trials which will say yes or no. But right now, I cannot give you the answer you would really like.
Okay, thank you very much.
So I would like to just to make a brief comment. It's my personal life philosophy is it's not about money but about the organization. So beside the fact that these therapies are right now very expensive, there is a very big problem in Serbia and Montenegro from the regulatory perspective. So I think that from this conference, this is what should be underlined, and what should all of us, if we want to try this therapy at least, would be focused in, is that all the papers we can talk that they are not long-term results. The results are like this or like that, but what every of paper in each indication of using of this therapy show its safety. So I think that we should maybe push a little bit the administration to accept this kind of therapy, at least for the research purposes, and then we can show the benefits or show that this doesn't work. Please, Milutin, have a question.
Yes, I would like to comment on the discussion between Mihailo and Leonard. I would like to add that one comment that actually all those therapies, local therapies, intrafistular therapy, so you can call it like that, with the mesenchymal stem cells are actually only adjacent therapies. So all those patients are already undergoing the more sophisticated therapies such as biologic therapy or any kind of immunomodulating therapy. So this is another adding quality on the attempt of healing of those horrible fistulas who are present there for several months, years, etc., etc. So of course we don't have long-term results. There are no long-term results. We have just case reports and case series, but we don't have large studies which are analyzing the benefit of the therapy with stem cells alone in comparison to another types of therapy. And this is also my question for Leonard. So what do you think? What do you think about? Is there any hope for the stem cell therapy to become the first line therapy, and not only the adjacent therapy to the anti-TNF therapy for Crohn's disease?
Yeah, thanks for the question. It's an ambitious thought. I would say that first a lot of work will be needed to be done on our side. So the majority of cell treatments like this is throughout the EU and probably here as well is made by either hospitals on their own or by small biotech companies like us. So there are few treatments per every employee of the company, because we need to really to work a lot for each patient. So therefore the prices are too high. So we will really need to lower the prices by augmenting the fields of use, so that price per treatment will be lower, but that we will be still sustainable. And from there on, perhaps it might be possible, but until then, I don't think. I mean, even also these biological drugs are working as they are, and they're well established. So for us to come in and to really become first line of therapy, it's gonna take a decade or two, I think.
Thank you, Leonard. I just need to comment. Let's be a little bit more optimistic because some biological therapies are maybe which are used today in not in Crohn's disease but in some other diseases are much more expensive than the production of the stem cells. I think. Oh, sorry, colleague. I think that Nicola wants to ask a question.
And I would have one question which probably is going to bring the story back at the beginning, but that's what I'm interested in and I would like to know. You mentioned several times that basically, if I got it right, the mechanism is that the stem cells are inducing some kind of anti-inflammation. Can you tell us a little bit more about it? Because that's basically what I would like to know. If I realize what kind of mechanism it's in the background, I would really endorse the story.
Yeah. Okay. So it's the point is that when mesenchymal stem cells, we do not activate mesenchymal stem cells at all when they are transplanted. But when they are transplanted, they communicate with the environment. So when they see that that the environment is inflammatory, actually they start mainly producing some interleukins and other cytokines to lower the inflammation via actually reducing the differentiation of cytotoxic T lymphocytes and also B lymphocytes, but lately actually that was the first theory, and it's been actually confirmed both in vivo and in vitro. But later on, it was really interesting that the cells, when they are implanted intravenously, so systemically, they actually they get into lungs. Like the majority of them during the first 2 days, it's located in the lungs, and then they kind of disappear from the system. So we couldn't really explain the long-term effect if they only suppress or they only lower the activity of B cells and T cells and some other cells for 2 days, then how can they work for longer periods? And then the one paper came out where actually the cells in lungs are engulfed by macrophages, which then turn from M2 from pro-inflammatory to anti-inflammatory, and it seems like they persist to favor anti-inflammatory macrophages over pro-inflammatory due to being engulfed by them. But I can explain later.
Thank you, Leonard. I think also, Nicola, that Professor Vojvodic will talk in details about the mechanisms. We are very short with the time now, so please, just one more question to colleague who already asked for that. And Leonard, please be as short as possible, but don't stay unanswered, okay?
Yes.
Thank you. I would like to add just one information. Today we already have approved the therapeutical agent in complex perianal fistulas in Crohn's. It's called alofisel, derived from adipose stem cells. You can check more information if there are any doubts in trial previously conducted. It's called Admire CD. So even in Serbia today we have that agent approved.
Yeah, thank you. I commented. I told about the authorized registered product. Yeah, thank you.
Dear colleagues, dear friends, first of all, I would like to thank a lot to Dr. Jihan Abazovic for his kind invitation to this meeting. This is actually a first meeting in live presence after I don't know how many months and years. So I'm very delighted, to be here with you, and also because Jihan is one of the leading experts in the field of regenerative medicine in general in the region. So I would like to give my contribution to his fantastic meeting. So as you can see, my topic is the regenerative medicine in gastrointestinal endoscopy. And as Leonard said before, there are several fields of interest which are covered by scientists who are investigating the role of stem cells and platelet-rich plasma, to be more precise. As you can see in the first row, of course, Leonard spoke in details about Crohn's disease and ulcerative colitis. Then we also have to mention the potential role of stem cells in treatment of pancreatic non-malignant diseases, especially in both types of pancreatitis and in pancreatic insufficiency. Then in the hepatic inflammatory non-malignant disorders, especially in fibrosis and fatty liver. And then also the refractory celiac disease in patients who are not responding well to gluten-free diet and who are depending on corticotherapy. And in the end, of course, I'm going to speak more about the endoscopic possibilities of application of this kind of therapy. And you will see also nice videos and photos about fistula healing. So as you can see, everything is more or less still in the experimental phase, and we will need many years in front to realize the real potential of this therapy. So this is this photo is representing the normal surface of the intestinal mucosa. And all those cells, enterocytes and other cells who are responsible for the immune response, like goblet cells or Paneth cells or even T cells who are actually behind the barrier, they are living in the perfect harmony. And they are representing a kind of membrane which is not permeable to the bacteria. In case of IBD patient, especially in patients with Crohn's disease, because this category is much more investigated than the other one, the ulcerative colitis, you can see the immunologically changed enterocytes and normal enterocytes together with another inflammatory cells like macrophages and induced T cells who are producing a lot of inflammatory proteins and responses. So the role of stem cell, especially if it's applied locally, is actually to block all those pathways, inflammatory pathways, and in order to down-regulate the local inflammation in these patients. So you will see in this photo right now, this is the thing that Leonard actually spoke before. A treatment of the fistula is a real nightmare both for surgeons and for gastroenterologists. It's going to take like several months, several years, and all those fistulas more or less are refractory. So this group of authors actually tried to besides the surgical treatment, they try to apply the stem cell, mesenchymal stem cells locally into the fistulous orifice, and then trying to cure it slowly, and then after 6 and 12 months, they obtain very, very remarkable results. As you can see, all the 12 months follow-up on those photos below. These first two patients were representing the perianal fistulas due to Crohn's disease, and this one presented the enterocutaneous fistula, who was actually reepithelialized and closed after 12 months. But I have to underline this is only the adjacent therapy, so not the first-line therapy. And this is the most philosophical question in this moment. Which is the real way, to treat those patients, to use the anti-TNF therapy, to use the PRP substrates, to use the MSC cells, or eventually to combine this therapy. So this answer will be, this question will be unanswered, and we will need to perform many more years in front of us, several very important research projects which are ongoing, especially in European Union, to realize the real benefit of this therapy. So regarding the pancreatitis and regarding the inflammatory disease of pancreas, actually, I must say that that we have better experimental results in the acute form of pancreatitis rather than in the chronic one. As you can see here on this slide, if you apply mesenchymal stromal cell therapy, they are succeeding to change the immunomodulatory effect, then to react as an anti-apoptotic cause, and then to enhance the angiogenesis, and of course to increase the antioxidant effect of the surrounding of normal pancreatic acinar cells. On the other hand, the good response in the chronic pancreatitis, if you apply MSC, then you can obtain the inhibition of pancreatic satellite cells who can be responsible for the increase of the immunological response. So this mechanism is very complicated. As you can see, you have this is of course animal model, and it's studied on the rat and mice population. So you have MSC, which is below on this photo, and due to several mechanisms, they are somehow stopping the apoptosis of the acinar cells, and they are trying to deactivate the pancreatic stellate cells who are responsible for increased immunological response. They're blocking the inflammatory cytokines, and they're also preventing the entrance of the macrophages who are increasing again the inflammatory response. At the end, of course, they are blocking indirectly the intestinal injury. Another thing is also the endocrine function of pancreas, which is a kind of topic of interest of Jihan and our team from Italy. So we are also investigating something in this field, and the study, which was actually the last and the only one published study, is actually presenting us the benefit of the intravenous or local instillation of mesenchymal stem cells into the pancreatic tissue. Of course, this is an animal model. In insufficient secretion of insulin, so in the diabetic mice. So this kind of diabetes was provoked by cutting and removing important part of the pancreatic gland in order to achieve the diabetic mice. And then they divided in two groups those mice. So they applied intravenously in one group and the locally in another group. So you can see that the increase of the population of beta cells is actually better in the animals treated by the local instillation rather than with the IV instillation, okay? And this is the control group. So this could be an answer, you know, in order to treat the patients with diabetes. Another example, as also Leonard said before, we know that wherever is the inflammatory action in some patient, there is a space for MSC therapy. So this is also an animal model. You see the fatty liver. Actually, this is the normal liver in rat, and this is the histological presentation of this liver. And then you have rats which underwent the high fatty diet. And this is the rats. These are the rats which underwent the high fatty diet together with the application of stem cells. So you can see the color is not that pale like in the second group, and also and the histological pattern. You see that this type of histology is closer to the normal one than to the high fatty diet rats. And all this because of blocking several fibrotic and inflammation processes such as hepatic stellate cells attenuation and the Kupffer cells activation reduction. So now let's go back a little bit to endoscopy. One of the most investigated parts of implementation of mesenchymal stem cells to endoscopy is actually the treatment of the lesions after the defects, after the polypectomy, and of course after the endoscopic submucosal dissection. There are several studies which are investigating the instillation, the injection of platelet-rich plasma in this case in the margins of the defect in 4 quadrants here. And then the models were followed up by endoscopy after 1 month, and then they concluded that actually the ulcer defect, which was treated with a platelet-rich plasma, actually heals quicker than the normal one, which is not treated by PRP. But in terms of complications such as delayed bleeding, there were no differences. This is another very interesting study, of course, animal one. This is a circumferential and very, very long defect of the esophageal mucosa done by the DSD of the esophagus. And then you see on the right side, you see the 4 examples. So the first one is the normal healing of this defect. So you can see stenosis almost in this part of the esophagus, which was treated by DSD. And the second one is that the pig which was treated by the oral application of mesenchymal stem cells on the weekly base, and this is the pig model which was treated with the application of the stem cells in the daily base, and this one is the control, another group which was treated only by the steroid, a local steroid therapy. So the best results are obtained in this third group. So it's the pig which was treated on the daily basis with the stem cells. So there is no stricture, and even the mucosa here is more likely to be a very good quality mucosa without fibrotic appearances. Another possibility to apply this therapy is actually on the rectal level. So they also, some authors investigated the possibility to apply the stem cells into the circumferential ESD, and they found that probably a kind of enema which can be made for each patient or each patient who underwent so big removal of the pieces of mucosa and polyps. They can benefit from the enemas which can contain the mesenchymal stem cells. So let's go now back to the healing of the anastomosis, which is actually the most important field of mesenchymal stem cells application. This is a German study which actually is presenting how difficult and how complicated is the multifactorial process of healing of the anastomosis. So there are many factors who are contributing the slow or fast healing and good healing, and one of them is actually the deficient matrix regeneration. Actually, this matrix of especially which is needed to obtain a good submucosal healing could be improved by installation of MSC, and the effect could be represented by the collagen stabilization and matrix regeneration. Of course, there are several other very important factors like malperfusion, who can be improved by the hyperbaric oxygen therapy, and deficient tissue recognition, which can be improved by the growth factors, and of course the dysbiosis, and we also heard that microbiota could play also a very important role in better healing of intestinal anastomosis. This is one Turkish study which proposed the usage of surgical sutures, which can be impregnated by the PRP, and in case of low dose PRP, which actually impregnates the suture, they obtain better results rather than the other group which was treated by the high platelet concentration. This is, of course, an animal model. So, endoscopic possibilities of treatment of fistulas are actually several, and we use almost all of them, but I can say that unfortunately we don't have a magic tool, and this is very difficult to treat, especially if you treat a chronic fistula. So this is our armamentarium. As you can see, we have several options here, but most of them are actually the mechanical therapy and not the biological therapy. As you can see, the ulcers we are treating by clips or injection of adrenaline, or another diversity of devices which are bipolar or monopolar, etc., and of course by administering of high dosage of PPIs. The anastomotic dehiscence of the surgical interventions, of surgical anastomosis, actually is following the development of surgery, especially the laparoscopic one, and especially in the field of bariatric surgery, when you have a lot of interventions such as sleeve gastrectomy or a bypass. And my center is dealing a lot with those patients, not only the primary but also the secondary, the revisional interventions for the weight regain, which is also a kind of regenerative therapy. So what should we do? We always have to, in case of esophageal fistulas, we have to see if the mediastinum is drained. We have to consult CT scans to look up for collections and to locate the surgical drains. But first of all, the most important thing is to perform high quality upper endoscopy with the CO2 and the cap in order to determine well the fistula's orifice. If we deal with a small orifice, then we use just a suture or a pigtail or a self-expandable metallic stent. But if we deal with a large orifice, we have to use endosponge or some other device, such as this one, which brought the revolution into the interventional endoscopy. And this is a kind of Apollo overstitch device. In this photo, this is a double channel device, but normally we now perform with a single channel overstitch, where we have an adjacent external channel which is attached to the cap of the tip to the endoscope. And with this kind of helix, we are grasping the mucosa and bringing into the jaws of this needle, and then we close the suture. You will see on the next video. So this is a small orifice of the treated bronchogenic cyst. As you know, the bronchogenic cysts are benign formation, but they are very tricky for a treatment because they can be infected easily, and it's very difficult to cure it. So in this case, we just closed with one stitch with this overstitch device, and then the control upper radiological study, we didn't see any kind of leakage. So how horrible one fistula could be, you can see on this photo. You see the big hole, and this is the anastomotic dehiscence of the surgical intervention. So we have to analyze very well the margins of the fistula. We have to see how far we can go in order to grasp the tissue and to close it by the endoscopic suturing device. In some cases, we can also perform the position, the placement of self-expandable metal stent. You can see on this photo, there is a big beta stent, or we call it mega stent, who can be long, like between 18 and 22 centimeters, and it has lateral bumpers here, which are preventing the migration, distal or proximal migration of the stent. And in this part, actually, we are trying to position the fistula orifice in order to be close both from above and from below. This is the graphical example. Of course, if you put a normal stent and not a mega stent with lateral bumpers, then the liquids from below can enter the fistula orifice and go out, so they have to be drained by the external drains. This is the endosponge. It is reserved for the big holes, and it works on the suction principle. So it's connected to the aspiration device, and then we put it endoscopically into the hole, and then we are retrieving it slowly. But this is very long-lasting procedure, and it's not successful every single time. So this is the endosponge. You see the big extraluminal cavity. And this is the cavity filmed by the endoscope, and this is the endosponge which was inserted into the hole, and this was the healing obtained by the endosponge at the end of the treatment. And this is the lumen of the normal esophagus. What about the self-expandable metal stents? You see the hole here, the fistula. Then we placed, this is a very long beta stent. Then on the radiological control with contrast medium, we don't see any kind of leakage here. And this is the endoscopic view. And now this you can see a kind of double pigtail stents insertion in the surgical dehiscence. You see here on this photo, this is the Ovesco clip which didn't work. So we had to place, of course, there is an external drain, and then we placed this catheter with a hydrophilic guide wire into the cavity. And then we placed the two double pigtail stents, which are 4 centimeters long, in order to give us the possibility to shrink the cavity and to drain it well. So this is the process. You see the red point. This is the distal tip of the external catheter, which is draining the fistula. Slowly by time, this pointing is moving towards the intestinal lumen, which means that the fistula, which means that the collection is slowly shrinking. And you can see it here. So it migrated even more there. And then on the further radiological control, we saw that actually the fistula is healing. So I can go a little bit quicker here. So the complications of anastomosis are actually early and late complications. We saw some endoscopic possibilities, how to treat it, and this is the procedure that we perform in our institution, which is actually reserved for the surgical patients which underwent already the bypass for obesity, for bariatric surgery. And in case of weight regain, in order to prevent this kind of dehiscence, we are performing the endoscopic revision of the anastomosis. So we are burning the anastomosis with the APC in order to increase the scarring of the tissue, and then we are starting to suture with several sutures the anastomotic orifice, and then we bring it up to the 7 or 8 millimeters, and we have very good results, and surgeons are very happy because they don't have to touch those patients. Another option is actually reserved for EOS, and in terms of placing the lumen opposing self-expandable metal stents into the cavities, which are communicating with the fistula, or some ideas, how to decrease the biliary pressure into the biliary tree. So this is also a possibility, or there is also a possibility for stem cells to be applied in these patients, but we never performed a study like that. Normally we are treating it by stent position. So you see the fistula here. There is a big leakage in the cystic duct stump, and then we place the nasobiliary drainage, and then we are resolving the stricture with multiple plastic stent insertion. We are increasing slowly with every next session. Every 3 months, we are inserting both diameter and the number of stents in terms of dilating the biliary tree. So as you can see, this was the first stenosis in the moment after the fistula, and then this is the last slide that showed the outcome of the whole treatment. The horrible fistula is also pancreatic fistula, And we have several possibilities to drain those fistulas from the endoluminal and intraductal positioning of plastic stents, or eventually of placement of the lamps in the vicinity of the pancreatic fluid collection. This is the conventional treatment for the conventional, because normally it's supposed to be done with two double pigtail stents. So let's turn back to the application of the mesenchymal stem cells in these patients. As I said before, we don't have a perfect tool to treat those patients, so we have to find another possibilities to treat them. One of them is actually the installation of the mesenchymal stem cell. This is a brand new paper which was done by our institution of Policlinico Gemelli and with the several international collaborators. So this is this schematic picture is actually presenting the harvesting of the adipose tissue, and then the separation of two fractions. One is the microfat, which is injected directly with a small catheter into the fistula opening, and the other part is processed. It's a longer procedure. We are processing this kind of liquid in order to obtain the this is stromal vascular, stromal vascular fraction, tissue-derived stromal vascular fraction. Jika knows it very well. And then we inject it around the fistulous orifice, okay? So this is the photo in the beginning, and this is the end of the procedure. So this is the case of one very big leakage. You see the hole, and it's full of liquid here. And it was tried to treat surgically, but unsuccessfully. Then it was tried to treat by position of the self-expandable metallic stent, which actually gave initial very good results because there is no leakage in those photos. But at the end, because you cannot keep the stent for eternity, the stent removal, we saw still, this kind of leakage here. And endoscopically, we can see a part of the esophageal lumen. We can see above here, there is the hole. This is the proximal part of the fistula orifice, which was communicating with that large collection outside the esophagus. So it's very difficult to treat because, with Apollo, you cannot treat as, such a big hole in this level. So you see the leakage here, and of course the most part of contrast medium goes to the gastric cavity. So this is a so-called harvesting with a special needle of the fat. This needle has also the lateral holes, which gives us an opportunity to harvest the fat tissue. And one part, as I said, this is microfat, is to be injected into the fistula lumen. And this is a kind of separation and filtering. They use special filters in order to obtain, this is a 30 milliliters liquid, and then they obtain just a little bit of, after centrifugation, etc. Just this is this one. The final product is that stromal vascular fraction. So this is the microfat which is injected into the fistula. You will see the yellow color. So this is the yellow color. It's like a fatty color. And then immediately after that, you treat the orifice fistula by circumferential injection of TSVF liquid. This is the paper just published in Gastroenterology this year. So this is the result. 1 week later, we see already the disappearing of the fistula. It's very important to do very nice radiological examination in order to follow up, and it excludes the necessity to enter every single time with the endoscope. And this is the final endoscopic appearance. So as you can see, the fistula disappeared. Of course, there is a kind of deformation of the esophageal lumen, but at least there is no fistula anymore. Okay. So another thing, there are several ongoing studies. This is a paper which will be published very soon, which is talking about the hydrogel. It's a kind of substance that was made by the nanocomposite hyaluronic acid, which is responsible for making a very nice, precise pattern. You can see this is the pattern obtained by this hydrogel. And the measures of those small holes in this pattern are actually about, most of the holes are measuring about 20 microns in the diameter. So this is the very high magnification, and this is very good because these small holes, like a nest, you know, they can collect the fibrocytes and the other submucosal cells, which can be, you know, used for to make a rebuilding of the tissue in kind of defects. So this is the pig model. You see the beginning and see the end. Due to this nanocomposite material, the work was done well. Of course, we are not limited only to the esophageal fistulas, but also the esophageal and also bronchial fistulas. So it can be done both bronchoscopically and endoscopically. And this is the last study which I brought here just to show that the regenerative medicine will have also probably an important issue in the treatment of the obesity and diabetes 2 type. This is a kind of Revita 2 study done by a special fractal balloon, which is actually a hydrothermal ablation of the mucosa of the upper of the duodenal mucosa. It's a kind of resurfacing because you burn the mucosa, and then mucosa is regenerating with the filling up with the normal cells, and with the hormonally active cells, which can also regulate the level of glucose into the serum. So you can see the both studies from Brazil and from Europe. They brought very good results in terms of the decrease of glycated hemoglobin, and the second one is actually the representation of the FibroScan and the share wave in terms of liver investigation. So they also benefit from this kind of Revita treatment. So the next step would be to recover, to fill also the defect with the stem cells, and it is going to be performed in the next study of Revita. So I would like to conclude that actually wherever you have the inflammatory response, stem cells can be used. We are mostly oriented towards the stem cell therapy rather than the platelet-rich plasma, at least in the endoscopy. We are still in the experimental phase, and I hope that especially in these populations with diabetes, obesity, we can have special results in the years to come. Thank you.
Thank you very much, Milutin. Thank you for the very, very nice presentation. Since that we are a lot on delay with time, I will ask someone from the audience that we have time for 2 questions. So does someone from audience want to ask something? Yes, please.
Thank you, colleague, for the very impressive presentation. Both of them are. I'm Marina Panišić. I'm a surgeon from Belgrade, but dealing most time in clinical nutrition, and as a surgeon dealing time with patients with gastrointestinal fistulas from the beginning to the end. So of course I'm very impressed with those data you gave for intestinal fistulas. You know, you are mostly talking about fistulas in the upper GI tract, but as well we have a lot of problems, real problems with treating patients with intestinal fistulas. Are they external or internal? It depends on the etiology. But I can tell you that the most, I call them surgical catastrophe patients. So anything that can help to avoid surgery in such patients without various etiology is very, very acceptable for us and very interesting for us. You showed one picture from, was it external? Have you heard everything?
Yes, yes.
Okay. With enterocutaneous fistula, and you told it was healed in 1 year. Well, it's a long time. It's a long time because you have from European Society for Clinical Nutrition, there is a special interest group for acute and chronic intestinal failures, and we have made protocols for treating fistula. So my question would be, there are a lot of things to do, recommended to do, and we really can heal fistulas, even interintestinal, in, let's say, few months. But after that, there is nothing. If we don't have answer on treatment, they have to go to surgery. I find out that we, with this kind of therapy, we could buy time for such patients and be more effective from upper to distal GA tract. Especially impressed is broncho-esophageal fistula, because they are really very, very difficult to treat. So we stopped before surgery with stents and have a good results, but we have to control the stents because of moving. Yes. So I really find out and ask you for your question. I think my questions would be, should we make all our therapy conservative therapy, including nutritional therapy, together with cell therapy, or could we wait as a last treatment before going to surgery? That's a very interesting question.
Thank you.
Thank you. Very nice, very good observation. Actually, the answer is that the treatment of this patient is, of course, multidisciplinary. And maybe, I don't know, several decades ago, surgeons were the team leaders in this situation, but now you have anesthesiologists, you have nutrition, as you said, you have gastroenterologists, you have endoscopists, you have molecular biologists, you have, you know, a lot of them are included in this kind of treatment. So in my experience, in the hospital where I work, we always discuss these patients, and then we are trying to, of course, to find the less invasive way of treatment. I must say that those pictures that you saw in the beginning are actually the Crohn's disease fistulas, which are very bad fistulas, because we speak about a permanent inflammation. This is not the kind of fistula after some surgical intervention, which is like early or a little bit later complication, which can be still treated both with endoscopy. Time. Okay, sorry. So, okay, this is the...
Okay, just a technical information. We are going without break, but still we don't have any time for questions. Now I can introduce... I'm thinking... I think you will... you have three more or less lectures. Yes, but between we have satellite I would like to introduce Dr. Bezmarevic, and we will start again in Serbian. Kompanija Inotek, satelitski simpozijum Dr. Bezmarević. Posle toga nastavljamo odmah sesiju, znači bez pauze, da bi završili na vreme. Jer smo više od pola sata prekoračili, izvinjam se.
Okay, so can we just, you give brief answer to the question to doctor, and then Bezmarevic can go, okay?
That one, okay. I just want to say that fortunately, at least if we speak about bronchoesophageal fistulas, we are able to act because it's very close and it's very easy. But if we speak about intestinal fistulas, you know, our limitations are great because we don't have so powerful instruments which can, you know, reach every single part of the intestine. So it's easier to treat from the endoscopical point of view, but from the clinical, probably it's more difficult to treat bronchoesophageal fistulas.
Thank you. Thank you. Ladies and gentlemen, dear colleagues, my name is Dr. Jihan Abazovic, and I'm emergency medicine specialist, but last 12 years I'm dealing just with regenerative medicine and trying to implement this method in the everyday practice. We place first two lectures which are technically maybe and clinically maybe much more depending, but I will try through my lecture to do the short as possible overview of all fields where we are today using regenerative medicine and try to underline some problems which we are dealing in the everyday practice. So first of all, we need to know that regenerative medicine is not field by itself, but this is a multidisciplinary approach when we are trying to use all the performances of our own body products, which are different kind of cytokines, adipokines, growing factor, etc., and in the end of the day to try to use our own cells in order to promote some traditional, more or less advanced medical approaches to different field of medicine. As you can see through this definition, we can say that now the regenerative medicine is not so young field. So this medicine is from 2004. This is 15 years ago. So we are slowly progressing, but I think that every step is very, very important. When we are talking about regenerative medicine, we need to know that there is something what we called autologous components and what we called allogenic components which we are using in the regenerative medicine. Why is this so important? Because through the regulation which is followed by Serbia and Montenegro and its European regulation, you are in minor or major way allowed to use autologous component for any indication if you are staying in something which is named minimal manipulative manipulation. From this side, we are using platelet-rich plasma, which Milutin discussed a little bit. This platelet-rich plasma can be enriched with other cells, such as leukocytes, can be activated when we are promoting the jelly form of this, and we can do something what we call bioregenerative fibrins. From the autologous stem cells part, there are few sources which I will discuss a little bit later more in details, but most of all we are using bone marrow, and the end product when we are using stem cells from the bone marrow, actually we are overusing the word stem cells because these are not specific stem cells, but this is part of the bone marrow which contains the most of the stem cells from some bigger portions. Also we can use SVF, stromal vascular fraction. This is where we are obtaining actually trying to obtain stem cells from the fat tissue. In certain indication, especially in hematology, we are using stem cells, autologous stem cells from circulatory blood. And in other part, when we want to ingrow each kind of these cells, including umbilical, fetal stem cells, etc., when we are ingrow them, we are able to not to use just mesenchymal stem cells, but we are able during the laboratory process to push them to differentiate in, for instance, chondrocytes or dendritic cells, etc. And these cells we are calling allogenic stem cells. Why? Because the In the most of the cases, donor is not the same, and we are using more than minimal manipulative procedure to obtain it. Clinical application of the regenerative medicine, and as we were able to hear earlier this morning, is very, very wide, and we can say that today we are using the techniques and technologies of regenerative medicine in almost all fields, specific fields of medicine. Just for your information, because I know that the platelet-rich plasma is something which probably most of us were deal in certain moment of the professional career. So just to avoid any misunderstanding, so platelet-rich plasma is part of the plasma which is enriched with the platelets. Inside the platelets we have all the tissue growing factors, and which are able to in some moment act in this here in the presentation mentioned processes, such as cell proliferation, tissue remodeling, to overcome or to deal with inflammatory response, and in the end of the day to promote or stimulate neoangiogenesis. Important step in this is activation of the platelets, which is the process when we are actually releasing the growth factors from the platelets outside. This will not happen if we don't use any kind of activator. Of course, they are capable by themselves in contact with the oxygen to become activated, but when we want to locally apply them, we need to use some of the methods of activation. Mostly we are using calcium, but the best way to activate the platelets is to use the autologous thrombin. Dr. Milutin in his presentation shows us the case when you are overusing or underusing the platelets, that there is a certain distinction between that. And if you are dealing with this part with this kind of therapy, please keep in mind that one of the most important thing is to make adequate concentration of the platelets. So this is some table which is theoretical approximation of the concentration of the platelets in certain applications, which are the most frequent indication where we are using this kind of product. Of course, in order to obtain quality control of the platelet-rich plasma, this is a very easy process, and you can use, just you need to make a strong discussion with the lab, because usually when they see that platelets are 2,000 and more, they are in the panic. But this is actually what we want. As you can see, this quality control you can do by basic blood counting, even with the 3-part differentiated blood counter. So we are using it mostly in the musculoskeletal pathology. I will not borrow you with the indication. You can read it from slides. We are using it in the aesthetics. Also, we are using it mostly and more frequently in osteoarthritis, when we have certain results. Most frequent grades of osteoarthritis where we are using this kind of therapy are grade 2 and grade 3, usually, because grade 1 I can make a parallel with hemorrhoidal disease with Dr. Mikhailov. We are not seeing the patient, so there is a long time from the first symptoms until the patient's coming to us. But most frequently in grade 2 and 3, and grade 4 is very severe for which need some kind of surgical treatment. Also, we can use intraoperatively this method. So when we are activating actually the platelet-rich plasma, and we are obtaining something what we call platelet-rich plasma gel, and we can place this product into any kind of operation. Mostly we are using this for reparation and of the tendons, ligaments, and for regeneration of the bones. Also, we can use PRP to do something what we call bone grafting. This is the cage for caging for spine, but this gives very, very good results, especially in the conditions such as non-union fractures. And when we are now, I will go to the part which is maybe more interesting and topic of our today's session. So this is the stem cells part. We are professionals, so we know that there are a lot of stem cells sources and lot of possibilities to use the stem cell therapies in this scheme. They are I mean mentioned most of them, not all, but what will be very important more important for us to know that we have through the regenerative potential, actually differentiation potential, we have totipotent, pluripotent, multipotent, and unipotent stem cells, and in the practice we are in the most cases using pluripotent and multipotent ones. Sources when we can obtain the stem cells, doesn't matter if we are talking about autologous or allogenic stem cells. First and most common used is the bone marrow, and from the bone marrow we are using specific needle. As you can see on the left and right picture, we are placing the needle in the any spongious bone. So mostly we are using iliac crest, but we are also can use tibia, vertebral body, and some other bones like talus, etc. We are drilling in the special trocar needle, and we are using the low vacuum in order to obtain the bone marrow. Then we can use it from adipose tissue. There is a process called liposuction, which Milutin also showed. This is the photo in the middle of the slide. So it's very easy to perform procedure when you can get the fat tissue and you can continue with the process of separation of something what we call stromal vascular fraction. And from circulatory blood, we are not using very often this kind of source, because we are using it actually just in hematology, because in order to provoke the stem cells to come in the circulatory blood, you need to use some neopogens, which are not so light, let's say, medicaments, and they have a lot of side effects. So this source, I mean stem cells from the circulatory blood, are just used in hematological diseases. When we are talking about isolation, when we take bone marrow, we are allowed to use just simple centrifugation when we are for certain amount of bone marrow, which is in adults between 150 and 200 milliliters. We are centrifuging it and trying to separate the part where the stem cells are. Let's say that if the counting in all the stem cells from this 200 milliliters, we are pressing in the few milliliters which we can locally apply. The end product, if we are talking about autologous stem cells, when we are using bone marrow, is called bone marrow aspirate concentrate. So again, in these cases, we are overusing the word stem cells. This bone marrow aspirate concentrate is part of the bone marrow which contains a lot of stem cells, but they are not purified, and there are also other cells inside. Also from the fat, we have more or less same situation when we are obtaining the tissue, actually fat tissue, by liposuction. We are using certain models of mechanical or enzymatic digestion of the fat in order to release the stem cells. And again, in the end product, which is called stromal vascular fracture, we are not obtaining the purified stem cells, but we are obtaining something which we call SVF, which have a lot of stem cells inside, but also some other cells and some other water component. This substrate prepared in this way, we can use as an injection, as a tissue matrix, and we can use it systematically. Also, both of these ways are enabling us to send these cells to the specified labs in order to ingrow them and to get some products. I will not stay because I try to explain the isolation. This is just in more details in order for you to see how look. So I get in details for also for bone marrow aspirate concentrate and for SVF, so I will not stay so long here. But what I want to underline here is that certain cells, depending of the sources, are showing better or less good performance since comparing to tissue when we are using it, and there are a lot of studies dealing with this topic. So stem cells from the adipose tissue are better in certain indication than from bone marrow, and in opposite. We are using also the stem cells in combination with the PRP and something what we call bioregenerative fibrin in order to make a scaffold for especially for osteochondral lesions, but also for chronic wound. And I think that this approach can be very, very successfully used for fistulas, which we mentioned earlier. And also we can use injections in orthopedic. These are some of these indications when we obtained very, very good results using the stem cells in the, for instance, avascular necrosis of femoral head or cartilage repair or after ACL reconstruction. But this is maybe for this auditorium today, maybe more important thing are the chronic wounds, when we really obtain very, very good results. And if you look on the also in the burning wounds and in the chronic wounds, when you look on the these three pictures in the middle of the slide, because I don't know does pointer work. So this is after 6 weeks we achieve this effect. Oh, sorry. And you can see on your left hand side the contrast angiography, when you can see that the leading arteria remains the same, but the collaterals after using of this kind of treatments are much more developed. We are also using this approach, actually stem cells in the cardiac surgery in two ways. One is to try to regenerate the myocardium after the infarction, and second way is to trying to reduce the blood loss and improve the healing in order to avoid the potential complications such as infection, not such as, but infection. Also, one of the ways which is maybe most complicated but most promising, and when we have personally best possible results, is using of this kind of substrates intrathecally, which means in cerebrospinal fluid, when we have protocols which are now also in the regular practice in some European countries, when we are using this for treating of cerebral palsy and some other neurodegenerative diseases. The process is more or less the same, and they are the anesthesiologists in the audience, so we are doing this intrathecal injection like you are giving the actually epidural anesthesia. Technically, also when we have a very good and promising results, and now we published 2 cases, and now we are preparing a big study which is in the, I think it will be published very soon. It's in gynecology, when we figure out the way to use the regenerative medicine methods, including stem cells, platelet-rich plasma, actually growth factors from platelet-rich plasma in combination with ovarian tissue, where we are modifying some signaling pathways in the ovaries in order to restore them and make them again functional even after menopause. And we have pretty good results in this field. This is very important and very big topic, keeping in mind that the women's now are planning the children's much later than it was maybe 50 years ago. Our program in this way, it's called Segova. I'm not going to go in details because we don't have so many time now. I can just say that we are using this technique in urology, and you can see the before and after pictures of cystoscopic picture after the placing this kind of product in the cystitic cystica. And also we are using this kind of methods to improve the erectile function in males and women, and also in the males we have success with some very severe erectile dysfunction in diabetics. About gastroenterology, I think that we covered this topic the most today, so I will not stay in this. I will just comment this, what Milutin already starts, and it's about our way of trying to treat diabetes type 1. We already perform animal studies, and we have approval to continue with clinical study in using of autologous stem cells locally and systematically in the pancreas. And also what we are doing now, since that we mentioned this topic, but according to the short timing which we have, we didn't have a chance to discuss it. Lennart mentioned few times that in the early beginning, when we start to use cells, we thought that they will be differentiate in the certain specific cell, so they will go from the stem cell to become some cells. This theory is almost fully abandoned now. We know that they will not gonna be differentiated, but what we are trying to use from these cells are the cell products. So these are some specific proteins, cytokines, but also some microvesicles which contains a lot of information which are able to functionally change the response of the local tissue, and this is actually the essence why we are using this. And this was not enough for our group, but we are now trying to deal with something what we call subcellular therapy. So what we are now doing as a basic research is to try to use the components from the stem cells to separate dead ones, which will help us improving some processes. This approach we use in the autism, and I can say now that we have, because autism is very difficult disease and it's not the same to every child. What we can confirm now is that most of these kids which are affected with autism are males. We don't know the reason, but from, let's say, 500 patients, we have just 2 or 3 females. And in this way we have improvement in the 70% of the treated patients with this kind of therapy, objective improvement in 3 of 5 scaling which we are using, actually not me personally, but our team of logopeds. So also now we are trying to develop something for treating we develop the concept for which can be used in all the neurodegenerative, but also in other diseases where the problem is some storage of the proteins or some components which cells are not able to push them out. So one of these diseases is MSA, and we hope that we will see how the result will be, but this concept we want to prove through this disease because we think that pathophysiologically it's closest to what we technologically and theoretically put in place right now. And when I discuss about these microvesicles, first of all, we are trying to separate something what we call the exosomes. These are like as Professor Šupić, which will have a lecture, she said that these are the envelopes actually sending the telegrams to the cells in order to change the function of them. And last but not least, how we see that developing of regenerative medicine, it's now on much more increased during all this COVID situation, in that in very near future here in our country or countries, we will have a chance to use gene therapy when we are able to modify especially immunological cells, first of all T cells, to genetically modify them to act specifically to certain disease. And I think this will be future for the hematological disease, but also for the most of the tumors. And I think that 2 years ago I will say that this is far future, but after this COVID situation, I think this is the reality. So thank you very much for your attention. I did my 30 minutes in 23, so if there is some short question, I am very glad to answer.
Thank you for the presentation, Dr. Jihan. It is era of new kind of treatments in medicine. I'm surgeon. I'm interested in several things. On my opinion, I'm thinking empirically and practical. On my opinion, regenerative medicine should be based for the patient with benign diseases which burden systemically health and health systems, including quality of life of them. So, you, on my opinion also, you need to evaluate such diseases like Crohn's disease, like, okay, autism is very interesting, but I need to comment something and ask you something. Do you have some data about two things? First thing, I will combine your presentation and presentation from Milutin. I will like you to ask, based on regenerative medicine for the therapy of pancreatic diseases, for acute pancreatitis, you need to react quickly. So there is serious question about that. Do you have available time for implement regenerative medicine in treatment of patients with acute pancreatitis? So that is serious doubt of that. Second thing is, okay, we have now a lot of patients with chronic pancreatitis, which burden themselves also and burden healthcare systems, not only in our country, but in all Europe, including exocrine pancreatic insufficiency, deficiency of liposoluble vitamins, serious systemic diseases, which repercussing exocrine pancreatic insufficiency, also diabetes. You mentioned diabetes type 2, which is also in chronic pancreatitis, but also diabetes type 1. My first question, do you think it would be very good to make some new proposition for new study for patients with chronic pancreatitis? Because that is also immunomodulation. With stellate cells, Milutin mentioned that, with irreversible process of inflammation which affect the pancreatic gland, do you think it will be useful for regenerative regeneration of pancreatic tissue? And second question will be, I'm a surgeon. You have serious problems regarding pancreatic surgery, including high morbidity and mortality rate after the resection procedures. Do you have any data about using PRP or some you mentioned regenerative medicine implementation during pancreatic surgery and after that to improve quality of, not quality of life, but improve survival and improve morbidity after pancreatic surgery?
Thank you very much for your question and for your comments, and I will try to be short since that I have 2 minutes. So for the first comment about timing, we can apply this kind of procedure even when we are talking of surgery or treating of acute pancreatitis. The time this procedure can be done perioperatively. So during the operation, you need 20 to 25, 30 minutes if you have team inside and you have established system. For the pancreatic surgery, they are there is a leakage of that data, but for hepatic surgery, for instance, in terms of bleeding, there are a lot of data which are supporting the regenerative medicine methods, again, in terms of stopping the bleeding and faster healing of the tissue. So I think that this can be also applied in pancreatic surgery. But to make the long story short, I think that we need much more evidence, but in order to get this evidence, we need to go from the stage 1, which is that there are very, very few, maybe no studies which are not confirming the safety of using of this. So I think my personal opinion is that we need to work together as we are doing now to implement this in research. So to show, to prove, or not safety. Safety is already proven, but to clinically to make the evidence-based medicine and to see if this really works or doesn't work, and this will help us all.
Thank you.
So please be fast because I have 1 minute.
Okay. Good presentation, and I would ask you about practical, in relation of practical point of view. Do you think that you need in first step, establish a specialization of regenerative medicine or some kind of sub-specialization? Because we in Serbia and Montenegro, we don't have that kind of specialization. Do you think it's important to be like a specialist of regenerative medicine? Maybe this can be first step to start to prove that is important research in that field, and that is important practical therapy, practical interventions in. Because maybe we can start with that, and together with our societies, our section, your society, and also.
I think that, thank you very much for this question. I think that this is the essence of the problem, that methods of the regenerative medicine are used by different kind of specialists trying to improve their own work, but not necessarily knowing everything about regenerative medicine. But I think this is the essence, to have the person who will know all the mechanism and help you as a surgeon or you as a gastroenterologist or anyone else to implement this therapy. And when you are talking about making the specialization, it's also in the worldwide there is not a clinical specialization. It's mostly like they are lot of PhD programs on this topic. But if we achieve this, this will be my dream.
Can I also comment here?
Yes, please.
Yeah, just I think the majority, I don't think there will be one specialization for regenerative medicine. Rather, it's good that we collaborate between each other and talk to each other, and we can all here put our expertise on the field and do something with it.
Thank you, Leonard. I agree. And I will now ask the Professor Vojvodic to continue with his presentation.
In the first place, I want to thank the organizers for letting me have this presentation, and I feel so sorry that I'm not with you guys there. Well, a little bit of basic science. Mankind was always fascinated with the regeneration process, probably because it is one step closer to immortality. And the mankind was always looking for legend and myths, from terrifying capacity of Hydra to restore his heads and to ever-suffering Prometheus. But as many times before, mankind was looking at the wrong side. Everyday miracle of regeneration were always beyond us, and that they were represented in the enormous capacity of what we call the lower animals to restore part of a tissue, part of an organ, or even a limb. Nowadays, we know that beside that, or more precisely, to be more precisely, a basic force of every regeneration is the stem cells due its capacity for a so-called asymmetric division, which means that in every division process, stem cells could give another stem cells proposing stemness and the cells of other cell type. Nowadays, we also know that there are stem cells in almost every anatomical part of our organism that can give progeny of stem cells in any other cell type. So, having that in mind, that stem cells are located in almost every anatomical localizations, and we are easily capable to isolate and propagate them. We have to ask, do they have the same characteristics and do they have the same biological potentials? In the first set of experimental data that I showed you, authors compared the mesenchymal stem cells that were isolated from the two anatomical parts of the body, namely lipoid tissue associated with fat tissue, mesenchymal stem cells, and palatinal tissue.
Professor, sorry.
Yes?
Are you changing the slides or not? Because we are just seeing your first slide.
I'm changing the slides.
No, unfortunately, we are not able to see it.
Sorry, but I'm on the third slide of my presentation.
We are not able to see it. I don't know.
Try to close it and turn it on again and share screen again, please, Professor.
Yes, of course.
Now
sorry.
Now you are okay. Now you are on the third slide.
It is the second slide. Sorry. Do you see now? Do you see some changes now?
Changes, no, but we see your third slide.
Okay. We will continue like this. Do you see that slide? Is there any changes now?
No.
And now?
Now, yes.
Okay. We will continue in this view. Sorry.
Okay.
So,
thank you.
Thank you for your information. I will continue from this. When authors isolated two kinds of stem cells, namely from the fat tissue and namely from the palatinal tissue, they have the same characteristics, namely they were adhering to plastic, they have a so-called dendritic shape, and they have even the same phenotypical markers as presented here, but they were clearly different in producing the key proteins like vimentin and tubulin. So they were clearly with a different biological potential. In another set of experiments, author compared two mesenchymal stem cells that were isolated from the same anatomical compartment, namely very popular Wharton jelly mesenchymal stem cells. To remind you, these are the mesenchymal stem cells that were isolated for the gelatinous sheet of cord blood vessels, and the mesenchymal stem cells that were isolated for the other part of the placenta. As you can see, this is boring detailed phenotypic investigation of these cells, and believe me, those two types of mesenchymal cell cells, they have the same phenotypic markers and the same level of expression of those phenotypic markers, but they were clearly different in producing of key immunoregulatory cytokine interferon gamma. In historic experiment, Japanese group of authors isolated mesenchymal stem cells originating from different anatomical localization, namely bone marrow, synovial tissue, periosteum, adipose tissue, and muscle of the same patient in the group of 8 voluntary donors. And they investigated their biological potential in a way that assessed how potential are they in making cartilage, how potential are they in making bone, or how potential are they in making fat tissue in vitro conditions. And as expected, bone marrow mesenchymal cells were equally potent in making all kinds of tissue, but synovial, surprisingly, synovial tissue-derived mesenchymal stem cells were equally good or more or less better than bone marrow-derived mesenchymal stem cells, at least at these 3 types of tissue. This experimental data is very important. These authors compared capacity of the stem cells isolated from either bone marrow, which is depicted as red bars, or mesenchymal cells isolated for the fat tissue, represented as green bars, in their capacity to produce growth factors. As you can see, red marked, bone marrow-derived mesenchymal cells were far more potent in their capacity to produce so-called general stem factors like hepatocyte growth factor or stem cell-derived growth factors, while fat tissue mesenchymal stem cells produced far more immunomodulatory stem cell factors or growth factors that are focused on activity on several groups. Why is it so important? It is important because if you have a goal to treat a patient that has already inflammatory disease, then the better choice of mesenchymal cells could be mesenchymal cells originated for the fat tissue. But if you have a patient or experiment, every experiment has a goal to be translated on a patient, of course. If you have a patient that has have a problem that need to be solved in some regeneration process, then the bone marrow-derived mesenchymal cells are far more better choice than fat tissue-derived mesenchymal cells. In another set of experiments that was already mentioned in presentation of Dr. Abazovic, authors compared biological potential or all protein producing capacity of mesenchymal stem cells isolated from three parts of the same patient, namely bone marrow mesenchymal stem cells, placental and maternal part of placenta mesenchymal stem cells. This is so-called transcriptome, and in here, every colorful bar represents one possible messenger RNA. So this could be considered as all protein producing capacity of some cells based on the different messenger RNA. As you can see in this profile, in these differences in this colorful profile, meant that mesenchymal stem cells from the bone marrow of the same person are clearly different from the mesenchymal stem cells isolated for their placenta, and even the placental mesenchymal stem cells are different in their biological potential if they are isolated from the two parts of the placenta. Do we have a picture and sound? Sorry.
Yes, everything is fine.
Okay. Now we know that mesenchymal stem cells are located in every tissue. All they could be easily isolated, they be propagated, they be used for therapy. Now we know the different tissue type dictate different characteristics of mesenchymal stem cells. Even stem cells from the same anatomical localization express different functional characteristics, and the answer that arises from this data is mesenchymal stem cells can do some repair. And is it all? Do we depend only on mesenchymal cells for everyday regeneration and reparation, or what is the question of other progenitors? Luckily, in every tissue, like exemplified here, there are a vast number of progenitor cells. This is just one anatomical compartment. This is schematically depicted arterial blood vessel. And you can see in every part of the blood vessel, intima, media, and adventitia, there are numerous progenitors. Those progenitors, when isolated and propagated in vitro conditions, cannot give hostilage bone or neural tissue, but they are very good in regeneration and they're very good in proliferation to other cell type of the vascular tissue. In other words, mesenchymal stem cells could be considered as rock stars because they could differentiate in other cell types, but we must have in mind that there are potent local regenerative forces that are doing everyday repair and regeneration job, which are equally important as mesenchymal stem cells. Another example here, this is a human heart, and this is, according to many of us, a center of our emotions, of course. And this is the last interesting organ from the immunological point of view. Until recently, until it was discovered that human heart also harbors a very potent number of progenitors that could give any other cardiac cell type, but they cannot give any other cell type. Namely, they have mesenchymal stem cells characteristic, but they are good after in vitro and in vivo conditions. They are good only in regeneration and reparation of the heart muscle itself. Is it all? Does we have or do we have differences between male and female, at least at the level of mesenchymal stem cells? There are two crucial experiments. At the one in vitro experiments, rat neural cells were exposed to injury caused by low oxygen levels. And after that, they were healed with mesenchymal stem cells originating from female or from male rats. And authors found that female bone marrow mesenchymal cells have a greater neuroprotective ability compared to male. In another set of experiments, rats were exposed to injury caused by high concentration of oxygen. Their lungs were injured, and after that, they were transfused with the preparation of mesenchymal stem cells originating either from female or male. And the authors found that female mesenchymal stem cells express much more angiogenic factors and interleukin descent, and between all, male animal cells receiving female mesenchymal stem cells have a greater improvement capability in vascular remodeling. So the answer was female are superior than us, unfortunately, at least at the level of mesenchymal stem cells. There is also much more. On this slide, this is the story of two Michaels. On the left side is younger Michael, that is Olympic athlete, and he is highly decorated with Olympic golds. On the right side is my favorite actor. He is also highly decorated with Academy Award winnings. Experimental data demonstrate that mesenchymal stem cells from the younger animals have high or preserved proliferative capacity, have very low accumulation of DNA damage, have minimal telomere shortening, and everything of epigenetic changes that we'll talk, that you heard from Professor Šupić, and etc., which means, or the final conclusion of this, that mesenchymal stem cells from the younger animals or younger individuals are more potent in repair and regeneration than older. Okay. Now that we know all about stem cells, we can successfully use them in therapy. And what are the clinical experiences in short? This is the EPIC data from clinical study of Losordo and authors. EPIC, because it was published 10 years ago. It was one of the first clinical studies using human stem cells treating some pathological disease. And it was so epic, it was so surprising and prominent that even Neostem company used them as marketing. Losordo and authors treated diabetic mellitus patients that had critical limb ischemia. They treated them with multiple intramuscular injection. They divided patients in three groups: patients that received so-called high dose of stem cells, meaning that they were giving them 5 million per milliliter of CD34 cells, so-called low dose group that were receiving 3 millions per milliliter, and the control group that were receiving saline. Results, which are nowadays considered not so impressive, were impressive 10 years ago, because the probability of amputation and duration of amputation-free survival was significantly improved in patients that were treated with high-dose stem cells preparation. These EPIC data were basis for the two strategy of regeneration therapy. One strategy was to increase the number of stem cells and to better qualification and standardization of stem cells that were given locally. And the other strategic path was to give mesenchymal or any other stem cells systematically. Systematic treatment with stem cells have one big obstacle, which is depicted here in this experiment. Namely, authors used specific model of a rat with injured liver. They succeeded to label mesenchymal stem cells preparation in specific market that were easily could be seen in specific imaging technique. And after transfusion or infusion of mesenchymal cell preparation, they found that most of mesenchymal cells were trapped or stopped in the blood vessels of the lungs, namely 75 of systematically give mesenchymal cells were stopped in the blood vessel of lung. The rest of 20 to 25% of the mesenchymal cells still reach the liver, which is a good or not so bad result if you treat the animals or even treat the patient that has injured lung or liver. But it is very bad information, that it is very bad data, very bad result if you treat animal or a patient at the end that has an injured heart or even brain, because none of the infused mesenchymal stem cells will reach that region. There are two strategies to avoid this. One of these was already presented by Dr. Abazovic. These are his slides, and unfortunately, I got the low resolution microphotographs because Dr. Abazovic was always in a hurry and he didn't get the chance to send us something better. But anyway, it is very reliable. You can see the patient with the artery-occlusive disease, which is treated with PRP plasma, two patients in the situation before and after therapy, which was resulted in very significant clinical improvement together with very reliable arteriography showing multiple collaterals. Nowadays, there are two scenarios, there are two mechanisms that are believed to be operating in any stem cell therapy. First scenario is older one and depicts when you use mesenchymal or any other stem cells in the therapy of namely injured heart. They will at least 1% if you give them systematically, or if you much larger percent if you use them locally. They will arrive at the injured heart or the injured place, and according to that scenario, they will transdifferentiate in the injured cells, and they will regenerate and repair the defect. The other scenario is much more important because it depicts that there are some other non-cellular based factors like microvesicles and growth factors that could diffuse from any part of the body that will reach the injured organ, and at the injured organ they will induce the local regenerative forces to do all the necessary repair and regeneration. This is the slide that depicts something that Dr. Abazovic already mentioned. There is a possibility of stem cells to regulate the reparation and regeneration of injured tissue far, far away from the stem cells, just with the function of some microvesicles that could be considered as an envelope carrying specific regenerative program. The situation with microvesicles is not so simple, because this is my favorite movie, and the microvesicle effects could be seen as three different scenarios or three different effects depending on the source of microvesicles and the situation. For those that cannot recognize here, these are three different and three main characters of Sergio Leone movie. These are the literal translations of Italian words. This is the good, this is the ugly one, and this is the bad one or evil one. The first microvesicles were recognized as evil one because they were products of malignant cells, and they were able to mediate non-wanted effects, for example, immunosuppression, further malignant transformation of injured cells, pathological proliferation of blood vessels, and preparing the so-called microvesicle niche for metastatic homing of malignant cells in the draining lymph nodes. Ugly or not so bad microvesicles are ugly by the situation. For example, here we see intestinal epithelial cells, and after the infection by Escherichia coli in susceptible individuals, those intestinal cells will produce microvesicle that will transform the function of intestinal macrophages to make them pro-inflammatory, and that uncontrolled inflammation will result in substrate of inflammatory bowel disease. And the good microvesicles are, of course, those originated from the mesenchymal stem cells or other stem cells that could recuperate injured heart, or even something that were planned, I think 5 years ago by Dr. Abazovic and all of us. We tried to cure pancreas in diabetes mellitus type 1 patients with shots of microvesicles and mesenchymal stem cells in order to attenuate autoimmune disease and to preserve pancreas, but we were stuck between good idea and realization in some organization and administration labyrinth. What is the future? In short, if we look at the intestinal inflammation, all the crucial pathogenesis mechanism, which means function of dendritic and autoimmune T cells, improvement of intestinal barrier, the modulation of inflammation, intestinal stem cell proliferation, and gut microbiota modulation could be induced in long terms by the preparation of stem cells and the preparation of stem cells product. And the good news is that not only stem cells products, growth factors and microvesicles could be useful or beneficial, but also there are the plant microvesicles that could be used in the therapy or prevention of such disease. This is not only idea. There is a large investigator group in Turkey or Istanbul, which already have a commercial preparation from the treatment of autoimmune rhinitis or hay fever. There are several good news. This is a paper relatively recently published where the group used Wharton jelly mesenchymal stem cells from intranasal preparation to ameliorate some unwanted bronchopulmonal inflammation. And I did not resist to give you this. This is information from the April 19th, and a few days ago. Stemgenics patented so-called new hope for multiple sclerosis patients. Namely, they are preparing intranasal preparation of mesenchymal stem cells for correcting the defects in multiple sclerosis patients. Of course, this is marketing, and it remains to see how efficient it will be, but just imagine how magnetically attractive this is for any patient with multiple sclerosis to have non-invasive and multiple chance to correct his diseases. So after all this, are we closer to the miraculous regeneration or regeneration capacity of the lizards? I don't know. It is just every regeneration process depends upon your attitude and expectations. Thank you very much for your attention.
We will proceed with Professor Šupić, also from Military Medical Academy in Belgrade, Serbia. She will talk about epigenetics impact on bioactive dietary compounds.
First of all, I would like to express my gratitude to the organizers and Dr. Abazovic for the kind invitation. Today I will talk about epigenetics and its connection with cancer and nutrition. Epigenetics describes heritable and potentially reversible changes in gene expression that are not coded by the DNA sequence. If we could compare this with Monet's paintings, the genome would be a basic frame or motif, and genome would be variations of the main motif that and these changes in light of in these pictures, in these paintings, are making an art out of epigenetics. The main epigenetic mechanisms include DNA methylation, histone modifications, and RNA silencing. DNA methylation is the most well-characterized epigenetic mechanism And it is based on the covalent modification on cytosine. And these changes have a key role in transcriptional silencing in a number of processes, including development and differentiation, genome stability, imprinting, X chromosome inactivation, aging, and cancer. Methylations of CPG islands in promoters of tumor suppressor genes are leading to their inactivation and malignant transformations. Histones have a dynamic role in the regulation of chromatin and gene activity. Basically, histone tails can be modified, covalently modified by acetylation, methylation, phosphorylation, etc. And generally, acetylation of histone tails is linked to transcriptional activation, whereas histone deacetylation is linked to the repression of gene expression. Non-coding RNAs, especially microRNAs, have emerged recently as one of the key epigenetics mechanisms, and microRNAs have a role in post-transcriptional regulation by binding to its specific targets. Target mRNAs, which induce the degradation of those mRNAs or inhibition of the translation. A number of microRNAs are aberrantly regulated and in cancer and can act either as tumor suppressors or oncogenes, depending on their targets. Methylation has a key role in differentiation and development, and this is a key mechanism that differentiates a zygote from and stem cells from differentiated adult cells. A major role of epigenetics in a number of physiological processes derives from that role in development and differentiation. DNA methylation is removed after the fertilization and is reestablished in the early development. It is held constant or stable during the life, but with aging, we can see decline of DNA global methylation and inducing the epigenetic mechanisms and DNA hypermethylation of tumor suppressor genes. These changes are seen to be a key link between aging and cancer. And in cancer, we can see rapid progressive increase of inactivation of tumor suppressor genes by DNA methylation. The connection between epigenetics, aging, and cancer have been studied on monozygotic twins, which have identical genotypes. Monozygotic twins have almost identical epigenetic profile in early life in childhood, but during the years lifetime, in late years, older twins have significantly different epigenetic patterns affecting their gene expression. The development of methylation-specific PCR, method of methylation-specific PCR, has established epigenetic changes and especially DNA methylation in clinical practice. One of the most remarkable studies was conducted on smokers, and the DNA profile from for key tumor suppressor genes was investigated, and the P16 and MGMT DNA repair gene was methylated years, almost 3 years before clinical manifestation of lung cancer. These findings was very promising. However, the first FDA-approved test for non-invasive colorectal cancer screening was approved in 2014, and this is the first test so far that is based on DNA methylation. So in recent years, 20 years, DNA methylation of tumor-related genes have been associated with the prognosis in a number of studies and a number of tumor types. Our studies are predominantly based on oral cancer, and we found that E-cadherin hypermethylation is associated with cancer progression and worse survival. And then we found that in tongue carcinomas, rank 3 was hypermethylated, in contrast to previous findings in head and neck cancers, cancers with similar etiology and localization, where this gene acted as oncogene and was hypermethylated. Then we observed that a high percentage of remission and recurrences in patients with cancer-free surgical margins. And we investigated DNA methylation in these cancer-free surgical margins and observed that hypermethylation is a frequent event, and one of the genes was associated with overall survival as an independent prognostic factor. Then we investigated the overexpression of DNA methyltransferases, key enzymes involved in that covalent addition of methyl groups. And in oral carcinoma, observed that DNMT1 was an independent prognostic marker of worse outcome. And the genetic polymorphism in the same gene was associated with the prognosis in melanoma patients. Our more recent studies show that in breast cancer revealed the differential expression of sirtuins, enzymes involved in deacetylation not only in histones but in a number of other proteins. And we observed that triple negative breast carcinomas and hormone positive subtype of breast carcinomas have complete opposite effects on patient survival. And these findings are suggesting that these sirtuins may act depending on context, and that these subtypes are truly molecular subtypes of breast cancer. Then next study was an interesting one because we observed that microRNA 183 was associated with high alcohol consumption and worse clinical outcome of oral cancer. Defining the epigenetic profile for predicting the chemosensitivity of individuals and individual tumors would significantly contribute to the personalized cancer treatment and would establish new field of pharmacoepigenomics. And indeed, DNA methylation of MGAT, DNA repair gene, has been established as a predictor of response to temozolomide in glioma. Since epigenetic changes are potentially reversible, there have been a number of studies investigating the use of epigenetic drugs. And it was interesting to see that some of the drugs that were in use more than 40 years were actually epigenetic drugs that acted as a suicide substrate for DNA methyltransferases. However, the problem with this therapy is a lack of specificity of targeting particular genes and the high toxicity of these compounds. The impact of diet on the impact of diet and epigenetic changes has been studied because genome is largely static and epigenome is dynamic and flexible, and environmental factors influence the phenotype through epigenome. So epigenome and epigenetic changes are a link between genome and phenotype. So impact of diet on epigenome and phenotype has been is obvious on honeybees. Larvae of honeybees, depending on their diet, can grow to be a worker or queen. Queens are fertile and have a distinctive phenotype. And although the workers and queens are genetically identical, when epigenetic studies reveal that the basic and only thing that differentiate them is epigenetic changes, predominantly DNA methylation. This phenomenon of nutrition has been studied also on agouti rats, where maternal diet rich in methyl donors changed the susceptibility of the offspring to the obesity and cancer. In this strain of rodents, maternal diet supplemented with methyl donors resulted in inactivation of a transposon in the promoter of this gene and resulted in healthier offspring. And the manifestation was obvious with the changes of fur, of the color of the coat. In humans, there is unfortunately several evidences of epigenetic transmission and influence of diet. During the Second World War, during the Dutch hunger winter, there was significant reduction in food delivery in Holland, and calorie consumption dropped significantly. 22,000 people died. What was observed years after that DNA methylation of imprinted insulin growth factor 2, even 60 years after that event, was stable, and showed the lower DNA methylation in that genes, and health issues persisted for two next generations. Then restricted diet during the overcalyx in Sweden famine resulted in that paternal grandsons of grandfathers exposed to famine during the pre-adolescence resulted in decreased mortality for cardiovascular diseases and diabetes, and increased the longevity. So the question was, is DNA methylation truly completely removed at fertilization and reestablished only during embryogenesis? Now it is known that there are some persistent epigenetic marks, predominantly metal groups, that are not completely erased during the gametogenesis, and that is the basics of human epigenetic transmission on next generation. Folate is essential for DNA methylation, since that folate metabolism is a source of S-adenosine key donor of methyl group in number of cellular processes, including DNA methylation. Alcohol impairs folate metabolism in a number of ways, including inhibiting DNA methylation activity. And in our study, we observed that heavy drinking individuals with methylene tetrahydrofolate reductase genotype TT, which is characterized by the low enzyme activity. In those patients with heavy drinking, we observed multiple DNA methylation, which has been associated with poor prognosis. A number of bioactive dietary factors have anti-cancer properties and can play important role in cancer prevention. It was demonstrated for a number of compounds, include folate, including resveratrol from grapes and other substances, that they actually act through inhibiting HDACs, histone deacetylases, or the DNA methyltransferases, or they're activating histone acetyl transferases and activating transcription. Numbers of studies have been conducted, and these are the main bioactive compounds. Genistein is shown to be a DNMT inhibitor and HDAC inhibitor and activator of histone acetylases, activating the transcription in tumor suppressor genes. Then resveratrol is also a DNMT inhibitor, but also activator of SIRT1. The SIRT1s are associated not only with aging, not only with cancer, but also with aging and longevity. Then bioactive compounds from broccoli, then epigenin from parsley, very sulfurous compounds from garlic, then curcumin from curcuma, which are also DNMT inhibitors and influencing on acetylation of various genes. The one I have been, the one particularly interesting compound is compound from green tea, which is proved to be very active, not only as a general inhibitor of DNA methylation, but there are evidences that is working on tumor suppressor activation. So nowadays there are a number of studies exploring these compounds, but to me most interesting is epigenetic effects of human breast milk. Biological impact of human breast milk has been well established and known for a number of years. And for several bioactive compounds has been shown that human breast milk have epigenetic effects. However, breast milk is a source of large quantities of exogenous microRNAs, and by which those microRNAs can influence T cell regulation, B cell differentiation. And there is a phenomenon of transgenerational transfer of information by microRNAs from mother to child after birth by breast milk, and which is involved in epigenetic programming of immune system. So all of these findings are reestablishing the Lamarckian inheritance of acquired characteristics. However, now it is now known that acquired changes of the epigenome, not phenotype, during a lifetime can be transmitted to the next generation and can be based of a number of psychological dysfunctions. To conclude, our epigenome is changeable and influenced by diet. And now we are going back in time in the Hellenic era and where Hippocrates said that in future, predicted that in future, food could be our medicine. Thank you very much for your attention.
So I think that we have the question from the audience, so I will ask Dr. Bezmarevic, please.
Thank you, Professor Šupić. I'm Dr. Bezmarevic from MMA also. I'm general surgeon. I would like to thank you for excellent presentation. This is a topic for all-day sessions. You know, not only epigenetics, but in the last couple of years, you have a new field in the medicine. It's named nutrigenetics. You know that also very well. At least, but not at last. We know in ESPEN guidelines, clinical nutrition and metabolism, it's proven that in Crohn's disease, in people with Crohn's disease, it's grade A recommendation that people who had fed by breastfeeding, they had lower incidence of Crohn's disease and long-term remission of Crohn's disease. That was epigenetics. We know that for more than 10 years. But in the last 10 years, maybe more, a little bit more, we know now that it is epigenetics, nutrigenetics. So my question will be, because we know that exactly that a lot of GI cancers has changing in epigenome, like methylation, like a lot of you describe a lot of mechanism of epigenetics in cancers. But on my opinion, that is also a lot of study of in that basis. But I think that nutrition can have more impact on epigenetics in GI cancers than on head and neck cancers, for example, I don't know, respiratory lung cancer, etc. And yes, I think it is a field of medicine with huge spectrum of research areas. And my question will be, why there is relatively low number of research studies which evaluate the correlation between nutrition and specific GI cancers. It's my thinking about that. What is the problem with that?
So thank you very much for your comments and question. I completely agree with you, but the answer of lack of significant number of studies is simple. Lack of they cost too much and their duration is too long. So to complete the actual studying of nutrigenomics, you should probably, maybe the studies are held, but the results are not published yet. So the cost is main problem. It was main problem to establish that model in our laboratory. The cost and the duration and number of patients that must be included for that kind of studies.
Okay, thank
you. Thank you, Professor. We have another question.
Okay.
Maria, please.
I'm Mirjana Rajlić-Stojanović. I'm the only basic scientist, I think, in the audience. I would like to thank you, Dr. Šupić, for the nice and informative presentation. I have just one question. Now with your research, with this epigenetics research, we know what are the mechanisms by which some food affects our health beneficially. So, but we always knew that garlic and broccoli are good for us. Huh? So I was wondering, is there any other novel recommendation that comes from this research? Is there some food that we can eat that can really induce epigenetic changes that will be beneficial for us?
Thank you very much. Actually, we say this in Serbian, pronalazimo toplu vodu. We are finding scientific evidences of the compounds we already knew and for centuries, and the food knew for centuries that are healthy, like green tea and garlic and so. And that co-evolution of culture changes and our experience is very interesting. But for some new compounds, there are only new evidences, but there is no synthetically made compound that can be used in future, like royal jelly and garlic, compounds isolated from this from green tea, for example, are manufactured as supplements. But in my honest opinion, I think that's a tricky one, because a compound from green tea, EGCG, is actually used as in chemotherapy of some patients. So my opinion that it's way better to use functional foods than supplements.
Thank you, Professor.
Thank you.
I have a question. I raised the hand. Sasha Ljubic is here. Can I defend?
Yes, please, Professor.
I was provoked by the last question. Thank you for that too. And excellent lecture, Goga. Thank you. Could you
Thank you.
comment on the influence of differential diet and some of the last slides that you gave on anti-cancer or prevention of cancers, then some specific diseases, and on the other side, longevity? So is there any new information that some of these foods would be more better for one hand, longevity, or to some other positive effects? Thank you.
Thank you. Thank you, Professor. Yes, there are findings of resveratrol influence on aging. This compound from grapes and blueberries is shown to be activator of sirtuins, and basically stimulating autophagia, which is nowadays very popular kind of diet for losing weight, is actually stimulating that basic mechanism of autophagia, and the resveratrol act on that mechanism and influence longevity. But with the combination with some other compounds and caloric restriction, we can stimulate autophagia and prolong our lifetime.
Thank you very much.
Thank you for that. I have another just clarification, just to be sure I understood well. One of your previous slides before this one actually stated that hypocaloric food before puberty of male would give prolongation of life of their descendant. Excellent.
Yes.
So this was actually the slide talking about.
Yes, actually, we can now say that that effect is the result of stimulation of autophagia, and can be a result of stimulation of autophagia and mTOR pathway and so on, probably by CRT1 gene or FOXO genes, and basically not malnutrition, but reduce calorie intake can prolong our lifespan.
No, so to conclude, we should reduce the calorie intake of our sons to be able to have grandsons and granddaughters live longer.
That's how I understood it.
Yes.
Good.
We should eat less.
So just to be aware that we have in the audience president of the National Society for Nutrition here, and she clinical nutrition, sorry, and this topic.
Then we should have a comment from this point too.
We don't have a comment, but we have another question, since that we are the topic is very interesting, but we are now late with time, so I will allow two more questions. Please.
Thank you. Thank you for your outstanding presentation. I would like to ask, are there any lifestyle changes except of dietary changes that can affect our epigenetic in beneficial way?
Actually, it's good that I'm on this slide. Basically, I think that either of these compounds or folate intake shouldn't not be taken without, but should be taken with cautious and with individual individually. So if someone has a TT genotype of this enzyme and is not capable of metabolizing folate, over consumption of folate and folate supplements would not be beneficial for them. So the field of individualized nutrition and based on genome and epigenome, nutri-epigenomics and nutrigenomics and nutri-epigenomics should be taken, I'm blocking. So I know that it's not very practical to analyze a genotype but it is, I think it is commonly conducted to analyze genotype before taking that kind of special kind of supplements and so. And functional foods are actually are used as medicine in epileptic patients where keto nutrition has given very good results of keto nutrition. But do we all need to conduct that kind of nutrition? I don't think so. But the nutrition as well as therapy intake should be individualized.
Thank you very much, Professor.
One short comment. I thanks for your great presentation, and also I would like to commend Jihans and my idea, such as the president of this meeting, Dileme and Kontroverze, to put this lecture like a last one in program. Because this lecture is some kind of sublimation of our work in the last 3 days about nutrition, microbiota, and this session, like your session about all of that stuff. Thank you for a great session.
Thank you, Professor Šupić. Please comment, Professor Šupić.
Oh, thank you. I just want to thank you. Thank you.
And I have one short question, and to open this to put this topic even wider, but I would like you to answer me with yes or no, and then we can further discuss in some other occasions, since that we are out of time. Since that you say that epigenetics is a dynamic process, do you think that epigenetics, it's, I will call it under the quotes, guilty for human race development?
Yes.
Okay, thank you very much. I will with this comment I will close this session.